So I think I'll go ahead and get started. I'm Dr. Kim Thornton. I'm a reproductive endocrinologist at Boston IVF. I've been in practice, for over 26 years in Boston and over 30 years overall. This evening, we're really going to run this as a live Q&A. So if you have questions about either your fertility journey, any questions about treatment that you've undergone, treatment that you're considering, etc., please write the questions in the chat and I will do my best to answer. Just a little background. At Boston IVF, we have centers all throughout Massachusetts, Maine, upstate New York, in the New Hampshire, in the in Rhode Island rather, in the New England area, and then centers further west and south in North Carolina, Utah, Indiana, and Ohio. Why don't we just start talking about IVF? I've gotten a few questions, so I'll start off with the first question that I've gotten, which pertains to embryo transfer. And the question is, one, does Boston IVF monitor embryo development past day 5? And two, are there advantages or disadvantages of a fresh transfer? So when we think about IVF, after someone has done a retrieval, the embryos, if you have enough embryos to culture, are cultured out to day 5 when they get to the blastocyst stage. And if you're doing a fresh transfer, if your endometrium is appropriately thick, and if you have not had any evidence of a premature rise in your progesterone, you might be eligible for a fresh transfer. If that's the case, we would do fresh embryo transfers on day 5. But if you have a cohort of embryos that are still developing, we will culture them to day 5, from not only to day 5, but we will include embryos and we will look at them on day 6 and on day 7 to see if they reach the blastocyst stage. We have pretty good data to show that embryos frozen on day 5 and 6 do very well and have similar implantation rates. Embryos frozen on day 7 still have a higher implantation rate potentially, especially if they've had genetic testing, than embryos that are, for instance, not tested. So we will freeze embryos on day 7 as well. And then the question of what are the advantages and disadvantages of a fresh transfer versus a frozen embryo transfer. We have looked at our data, and we looked specifically at the hormonal profile of individuals when they were undergoing a fresh IVF cycle. And for individuals who have normal response, meaning that they're not at risk for producing too many eggs where we're worried about hyperstimulation, if we looked at progesterone levels on the day of trigger and stratified individuals into groups of progesterone levels less than, I think, 1.2, less than 1.5, and then above 1.5. And we saw that as the progesterone levels rose, implantation rates declined. That being said, for embryos that are untested, the implantation rate of a fresh embryo that was untested and transferred was still higher than a frozen embryo transfer that was untested. So we will do fresh embryo transfers if the progesterone level is 1.5 or below. If the progesterone level on the day of HCG is over 1.5, we will typically then make the decision to freeze, with rare exception. If the embryos are frozen, then we proceed with either a frozen embryo transfer on either a natural cycle or a synthetic hormone replacement cycle. And the decision as to the type of cycle we use for the embryo transfer is really based on your individual characteristics. I typically start off with natural cycles if the female partner who's receiving the embryos has regular cycles or has ovulatory cycles on, let's say, letrozole, which is a medication to induce ovulation. And if somebody's totally anovulatory or the cycles are unpredictable or I'm trying to target the embryo transfer for a specific day, then I'll use a synthetic cycle. So another question is after a chemical pregnancy, a biochemical pregnancy being a pregnancy where an embryo implants, the HCG level starts to rise and then falls before we get any ultrasound evidence of implantation. How long do you need to wait after a biochemical pregnancy? And a lot of it depends on how high the level gets. You know, for some biochemical pregnancies where the level gets to, let's say, 20 and then falls quickly, you could probably start to try to conceive in the following cycle. And at most, if the levels are much higher than that and your cycle might be a little bit irregular, I might take a month off in between just to make sure you can predict when you're ovulating, etc. Are IVF cycles willing to implant two embryos with the objective of conceiving a twin pregnancy? You know, that's a very interesting question. Historically, we transferred many, you know, one or two or three embryos when the implantation rates of embryos was significantly reduced. But as the IVF success rate got better, we found that we were getting a very high percentage of pregnancies that were multiple, either a twin pregnancy or oftentimes triplet pregnancies. We follow the ASRM guidelines with regards to the number of embryos to transfer. And the guidelines were developed with the objective of reducing the incidence of multiple pregnancy. So for women less than 35, typically the recommendation is to transfer one embryo. For women between 35 to 37, it's one embryo for the first few embryo transfers, and we might be a little bit more liberal if there have been failed embryo transfers with untested embryos. And it's only when patients are probably over the age of 38 to 40 where we may consider transferring two embryos. If the embryos have had genetic testing, you know, so the preimplantation genetic testing, then irrespective of age, the implantation rate is approaching high 40 to 50%, in which case we would only transfer one embryo. Another question, if someone's struggling with uterine fibroids, would it be best to do intrauterine inseminations with letrozole or Clomid? So uterine fibroids are non-cancerous tumors that develop and grow within the muscle of the uterus. And they can be located in a variety of different sites within the uterus. They can be on the outside of the uterus. They can be in the muscle of the uterus. They can be in the muscle of the uterus and centrally located so that they impact the uterine cavity or impinge on the uterine cavity. And so it really depends on the location of the fibroids. If you have fibroids that are central in the cavity, those are recommended to be removed before you try to transfer an embryo because it negatively impacts implantation rates. If you have a very, very large fibroid burden, meaning you have multiple fibroids all over the uterus with distortion of the uterine cavity, the recommendation is to remove those fibroids. Hopefully that answers that particular question. Let's say, are there any negative side effects for genetic testing of embryos? So preimplantation genetic testing of embryos for aneuploidy, where we're trying to screen for abnormalities in the number of chromosomes, has been very well researched, and the embryologists that perform the embryo biopsies are very skilled. We started off doing embryo biopsies on embryos on cycle day 3 when the embryos were at the cellular stage, somewhere between 8 to 10 cell embryos. And while we got good results with regards to the embryo biopsy, we did notice slightly lower implantation rates of those embryos when they were transferred back as compared to embryos that are not biopsied. With embryos that are cultured out to day 5, 6, or 7 and biopsied then, those are embryos that have well over 100 cells, and the embryo biopsy results in removal of only 5 to 10 of those cells. When we've looked at the implantation rate of embryos that have been biopsied at the blastocyst stage, there does not seem to be any reduction in implantation rate or embryo development of those embryos. So I would say that the genetic testing of embryos from the standpoint of technically is fine. With any diagnostic test, none of the genetic testing does have an inherent error rate where probably less than 1 to 2% where you might have an embryo where you biopsy and it comes back normal, and we find out that the embryo may have had another segment of the embryo that ultimately developed into the fetus that was abnormal, but that's not common. Another question. I understand that some fertility clinics will not accept frozen eggs from other institutions. And does Boston IVF accept frozen eggs? And I'm going to answer the question with respect to eggs and with respect to embryos. With respect to frozen eggs, we will accept frozen eggs from other institutions. I think that before we accept these eggs, we make sure from an embryologic standpoint that we understand how they were frozen, so we're able to thaw them. And our laboratory does their due diligence in working with the lab that initially froze eggs to make sure that we're able to thaw them successfully. Same with embryos. We will accept embryos from other institutions. If the embryos have not been genetically tested, that's one thing. But if the embryos have been genetically tested, we will accept all chromosomally normal embryos and all embryos that are unaffected with any disease. If you have an embryo that you've kept frozen because it's affected with a single gene mutation, for instance, we would not accept those embryos. We also would prefer not to transfer in embryos that do not meet the morphologic quality that we would freeze. So for instance, we freeze blastocysts typically that are stage 3 blast to stage 6 in grade A or B. There are some centers that freeze blasts that are stage C based on the Gardner classification or grading system. And we would recommend not accepting those embryos because the survival of those embryos is very poor. But our embryologist, again, will review the embryos that you would like to ship in first and tell you whether we would accept them or not. Another question. Is it normal for your menstrual cycle to vary in length after an egg retrieval? For this particular patient, she had an egg retrieval in December, and her last 2 cycles have been a little bit longer, 38 days instead of her normal 28 days. And when can I expect this to regulate? In general, it depends on the type of cycle that you've had. If you have a cycle where you have a lupron trigger, oftentimes you will get your period early, and then the next cycle may or may not be regular. It's not typical that, but let me just step back. Your cycles should return to normal fairly quickly. Without knowing anything else about you, if you're older, over the age of 38, 39, you might have irregular cycles after a stimulated cycle. So all of those factors play into it. So I don't know if I can answer it more specifically, but typically your cycles go back to normal pretty quickly. Let's see. So the question is, how long is a IVF cycle if you're going to do genetic testing? So a typical IVF cycle, we start stimulation on day 3 of your cycle. You're taking gonadotropins, which are the hormonal medication that stimulate follicular development, for somewhere between 9 to 12 days. So that takes you out to day 12 to 15 of your cycle. And then the retrieval is probably somewhere between day 15 to 17 of your cycle, okay? If you were doing genetic testing, then the embryos are grown in culture after they're biopsied on day 5, 6, or 7 post-retrieval. So they are biopsied cycle day, let's say 19, 20, 21, thereabouts, right? We send those, we freeze the embryos, send the cells off to the laboratory, and it takes the laboratory about 7 to 10 days in general to turn that test around and give us results. Most individuals will get a period about 7 to 10 days after the retrieval. So it's really difficult for us to do an embryo transfer cycle, the immediate next cycle. And part of that is because we may not have the results back. For patients who live in Massachusetts, where we have an insurance mandate, every treatment cycle that we do has to be pre-authorized by insurance. So we have to send the authorization. It takes 3 to 4 weeks to get back. So we always lose a cycle in between. So I would say, for example, if you do a retrieval in January, your transfer would probably be in March. And unfortunately, because we do have to get insurance authorization, it's very rare that we can do back-to-back cycles. There's some insurance companies that turn things around quickly, but the majority do not. Another question. I will be 34, sorry about that, when I try to conceive. As far as we know, we don't have any fertility challenges. I had frozen eggs harvested when I was 29. Due to my age, should we try to use frozen eggs or conceive naturally? So when you are freezing eggs for elective fertility preservation, the idea behind those eggs is to have a source of eggs that are quote unquote 29 years old that are going to be available to use when you kind of reach the tail end of your reproductive lifespan. And the reason I say that is at 34, you're likely to either spontaneously conceive on your own when you try, or even if you need fertility treatment, may have success on the first or second attempt and have your first baby with fertility treatment. Now, one of the things that you can consider is using the frozen eggs if you're doing IVF anyway, but I probably wouldn't electively use your frozen eggs because at 34, you're still very young. I would probably start using frozen eggs either if there's evidence of a decline in your ovarian function, a pretty significant decline in your ovarian function, or if you're over the age of 40, because the idea is to take those eggs and kind of extend your reproductive lifespan. So I'm going to try to shorten this question, but for someone new to the idea of fertility treatment and getting ready to pursue fertility treatment, what are the potential range of options that might go before moving on to IVF? So a lot of the answer to this question depends on the cause of the infertility. So that if you are, I would say, less than 35, and this varies again, have diagnostic testing where the diagnostic testing is completely normal, and you've tried for just, let's say, a year, then you may want to start out conservatively initially with intrauterine inseminations combined with ovulation induction to see if you can really enhance the hormonal environment, make sure that sperm is getting into the upper reproductive tract, and make sure the timing is right before you go on to something more aggressive. If you're in the 35 to 40, or if you're above 40, you might want to go directly to IVF because as IVF success rates, or as women get older, IUI and IVF success rates are lower. And so you might want to be more aggressive. If you have a condition, let's say, where you don't ovulate, let's say you have polycystic ovarian syndrome, or you have hypothalamic amenorrhea where you're not ovulating at all, there may be some benefit to trying to enhance ovulation and try it on your own for a little bit. But I think the older you get, the more likely we are to be more aggressive and move on to IVF. If you have a condition such as hypothalamic amenorrhea, and that's where you don't ovulate at all because the signals from the centers in your brain are not stimulating your pituitary, which then is not stimulating your ovary. Then we need to either stimulate your ovary with medications that are given by injection, so you get both a combination of FSH and LH, so you can not only produce estradiol but get a follicle to develop. And we can try intrauterine inseminations for a few cycles. But again, just because you're not ovulatory doesn't mean that your ovarian function hasn't continued to decline, even though you've not been ovulating. So you're every month or, every cycle, or it's all pre-programmed. So you're losing eggs as you get older. So I think that the older you are, the more likely we are to go to IVF directly. But I think we also evaluate things on a case-by-case basis, and take into consideration what your wishes are once you have all of the data that we discuss that's specific to your particular case. Question, is there a recommended number of available euploid embryos that somebody should have before trying an embryo transfer? The short answer is no. I think that we can, I run into patients all the time who would like to bank embryos so that they can have embryos to transfer now to try to have a pregnancy and have embryos available in the future. So for instance, if they get pregnant, so they know they have chromosomally normal embryos available once they've delivered, so they don't have to do IVF again. Kind of in an ideal world where there are unlimited resources, sure, banking embryos makes sense. But it's expensive. Most insurance companies will not allow you to bank embryos. So I can't say there's a number that you should have. I think that for most patients, and if it's not for you specifically, but when you're talking in the community, our job is to get the message out to the community that individuals should try to have their babies early enough so that they can hopefully have the children that they want to have in the normal reproductive lifespan, so somewhere before 40. But I recognize that's not always the case. I think that patients are always challenged by the fact that I may see you at age 40 and you want to have 2 children and your insurance doesn't allow you to bank embryos. I'm not so sure what else we can do but try to have one baby at a time. Exercise during treatment cycles, whether it's IUI or IVF, the question is, can you continue to work out? My recommendation is yes, but I think you have to modify your exercise based on what you're doing. So if you are the kind of person that goes to the gym 3 to 4 times a week, walks on the treadmill, for 45 minutes, 30 to 45 minutes, does light weights, that's fine. If you're doing CrossFit where you're doing high impact, high intensity activity, when you're undergoing stimulation, you have to remember that your ovaries are getting bigger and bigger as you go throughout the cycle. And with all that high impact activity, they're going to hurt. And so to me, it's just common sense that you just kind of back off. The other thing is there is an increased risk of the ovaries undergoing torsion, when they start to become enlarged. And with high impact activity where you are, either running or jumping or doing a lot of, exercises where you're turning and all of that, it's easy for your ovaries to torse. So we usually recommend that you don't do that. For women who are post-retrieval, again, your ovaries, one, hurt. And secondly, you've had a retrieval, you're down a little bit in terms of blood volume. So I usually recommend that patients take it easy for a couple of days and then reintroduce activity, initially lower impact activity, and hold off on doing anything really, really high impact, including running until your ovaries have had a time to involute. So that's usually about 7 to 10 days. So it doesn't mean you can't exercise, but you just have to really modify what you do. Um, so this is a question from a patient who says, during her first pregnancy, the patient and her husband both tested positive for an autosomal recessive disorder. Autosomal recessive disorders in general are where each parent or intended parent or prospective parent carries one normal gene and one affected gene. So if you have children, there is a 25% chance that a child could be completely unaffected, 25% chance that a child could be affected with the disease, and a 50% chance that they will be a carrier. Now, in this particular instance, the single gene mutation, causes maybe some disfigurement, such as, but is not necessarily a fatal condition. And so the question is, what is the process for genetic testing? And in that case, you're going to have to do an IVF cycle, but before you can even start an IVF cycle, the lab that does the genetic testing for the single gene mutation in the embryo has to get samples of your DNA, make sure that they can identify the mutation on both the wife's, the maternal gene and on the paternal gene, and create a probe or a test that they can then use to hybridize to the embryonic cells that ultimately they receive after the embryo biopsy to identify whether an embryo is affected, is a carrier, or is unaffected. And then in addition to that testing, we also offer patients the opportunity to do genetic testing for aneuploidy, because you would hate to find an unaffected embryo that, is a carrier of trisomy 18 or trisomy 21 or monosomy 16 or something that would result in a miscarriage or failed implantation. So that the timeline for doing a cycle is really predicated on how long it takes to develop the probe. And in some instances, you also have to get, in addition to the immediate maternal and paternal, you have to involve other family members to get more specific, get additional DNA samples to make the diagnosis a little bit more certain. Question, if you're working with a specific physician at Boston IVF, is that the person that does the procedures? And if not, will you have met the other doctors that may be doing it? And do we have residents and or fellows? So the way that our practice is set up, and the way pretty much all IVF practices that are, similar size, is that each physician has a panel of patients that they take care of, that they manage the decisions the decisions on which treatment to pursue. And then they manage the treatment cycles throughout the stimulation phase of the cycle. Because, we have centers in multiple places and we have physicians, we have a number of cycles. We have one doctor of the day that's doing retrievals and one doctor of the day that's doing embryo transfers. And by and large, they do all of the retrievals and embryo transfers that are scheduled for any given day. So unless you have a particular reason for your specific physician to do the procedure, such as having a very, very difficult embryo transfer, or, needing to have a specific type of a retrieval, let's say an abdominal retrieval, where there's only a few physicians in the practice that do that. By and large, we can't guarantee that your physician will be the one doing your retrieval and or your transfer. We do have reproductive endocrinology fellows, and these are individuals who have completed a residency or in fellowship training to become reproductive endocrinologists. And we have 3 fellows currently. Our first year fellow works with us, learning how to do procedures, and is supervised with a one of the attending physicians in the office. By the time our fellows are third-year fellows, they're oftentimes able to do, or they're always able to do retrievals on their own, making sure that there's an attending physician in the building, if not in the room. You can always make a request not to have a trainee, but we don't let the trainees do anything until they have completed, well over 100, 150 cases. And quite honestly, that's more than some reproductive endocrinologists in some practices do their entire fellowship. Our residents, we do have residents that don't do procedures, but they are oftentimes in the room observing. We do have residents that may be doing your initial history and then presenting it to the attending physician, and then the attending physician meets with you after. So because we're part of the Beth Israel Deaconess Medical Center training, part of their academic practice, and are obligated to do that teaching so that our residents are well trained, so when they're out in practice, they know how to evaluate patients for infertility, they know how to recognize when to refer, etc. So a question about patients with polycystic ovarian syndrome: how effective is myo-inositol with someone who has polycystic ovarian syndrome? So in women with polycystic ovarian syndrome, there is a phenomenon called, or they may develop insulin resistance, where they have a predisposition towards having either impaired glucose ability to metabolize glucose. So oftentimes women with PCOS are either pre-diabetic or at risk becoming pre-diabetic. Myo-inositol is thought to act in the metabolic pathway for insulin and improve insulin sensitivity. That being said, I don't think it necessarily corrects the predisposition, but it may improve your ability to handle glucose and maybe improve the sensitivity to insulin. I'm not so sure it's related to the other question is if you've had a miscarriage within the last year. I think that women with PCOS may have a slightly higher risk of miscarriage because of the hyperandrogenic environment, etc. So, all of the things that you can do to improve insulin sensitivity, will potentially help. Probably, you didn't mention issues such as, weight, but certainly weight loss in women with PCOS who have BMIs over 30, 35 will also improve insulin sensitivity. So, it's a combination of factors that you have to consider. Question about patient who has an endometrioma that's about 3 centimeters. How risky is IVF? So endometriomas are cysts that can exist in the ovary as a result of endometriotic implants, and the endometriotic implant is tissue that's similar to the endometrium that implants on the surface of the ovary or within an ovarian follicle, and then just every time you get a period, it bleeds like a period as well, and you get this cyst, this chocolate cyst. A 3 centimeter cyst, I wouldn't worry too much about. Certainly it is characteristic of probably moderate endometriosis. With IVF, you usually can do retrievals and avoid putting the needle where you're doing the needle aspiration into the endometrioma. But I probably wouldn't do anything with an endometrioma of 3 centimeters. Larger endometriomas, sometimes we recommend having those resected. The challenge there is when you resect the endometrioma, there's always the risk of damaging the capsule of, the remaining capsule of the ovary and reducing ovarian reserve. So you have to watch them and make a decision when you think surgery is appropriate, but a 3 centimeter cyst, I would just watch. So the question about age, and is there a maximum age that we're willing to work with? So the question is yes and no. I don't necessarily have a slide that I can show you, but we know that fertility rates decline as women get older, and the likelihood of pregnancy over the age of 44 is probably less than, depending on what the ovarian reserve screening is, less than 5%, and oftentimes even lower than that. So we typically do not offer IVF where we do a retrieval in a woman with and trying to retrieve her own eggs over the age of 45. And then anybody above that age, we would recommend that they do try to conceive using an egg donor. And that's because the pregnancy rates are, once you're over the age of 45 are probably even, 1% or less, if you respond at all. For women who are between the ages of, or who need donor egg, we will do egg donation up until the age of 50 for your first pregnancy. And then if you have frozen embryos, we will transfer your second embryo, or additional embryos up until the age of 52. Any special accommodations or recommendations for women not living in the United States? So the challenge in not living in the United States is we can't practice medicine across state lines. So that if you were coming, let's say from Canada, we would, you could potentially have, depending, you could probably come to Boston, have a consultation. We could make recommendations as to what testing you should have done. Your OBGYN could do that testing in Canada, and then you could come to Boston so that you could undergo treatment. It's very difficult to practice across state lines and internationally. Next question, if genetic testing shows all abnormal embryos, can we still decide to transfer one of these? So this is a very good question because it raises a lot of ethical questions. So the first question is, if you're testing embryos for chromosomal aneuploidy, so you get an embryo back and it says that the embryo has trisomy 21, Down syndrome, we would not recommend transferring that embryo back, and would probably not, I don't think that there's any physicians that would agree to that. If you have an embryo, and we used to test for mosaicism where there are two cell lines within an embryo, and there are some embryos where we know that if they're mosaic and the abnormality is the dominant abnormality in the embryo and implants, would result in a live birth of a baby that would be severely handicapped, we would not transfer that. We would transfer some chromosomally abnormal embryos if we knew that, if they were mosaic and we knew that there was no possibility of live birth if they did implant. And there are some embryos, and a lot of it depends on the center that does the genetic testing, but there are some embryos that have segmental aneuploidies, meaning that part of the chromosome is either missing or there's part of a chromosome that's added. And again, depending on the chromosome, we might, under certain circumstances with additional genetic counseling, agree to transfer those embryos. But it has to, there has to be a lot of counseling, and you have to have physicians that are willing to participate in that. But by and large, I would say no, our preference is not to transfer embryos that are abnormal. Likewise, for embryos that have genetic single gene mutations, again, I think it depends on the mutation. So for instance, we have been approached by patients who have had their only embryos remaining may have a BRCA mutation, or may have a condition that is associated with maybe disability, but not fatal and not severe disability. And so we might have discussions about those embryos and decide whether we would transfer them or not. But by and large, I think that if you're going to consider transferring abnormal embryos, you really have to examine why you're doing the testing in the first place. Because you all, especially for aneuploidy, because you can elect to conceive and have that embryo tested in the first trimester with the non-invasive prenatal testing. Question about the difference between somebody whose plan includes ICSI or intracytoplasmic sperm injection versus someone whose plan does not. Intracytoplasmic sperm injection is a technique of fertilization that is really designed for individuals where the male partner has a male factor, either low sperm count, low sperm motility, poor morphology, sperm that has been surgically harvested, or patients who have had prior IVF cycles with poor fertilization. So then we do ICSI somewhat empirically just to try to improve fertilization. So that if you're doing an IVF, your partner has a normal sperm count, motility, and morphology, the first cycle typically will be done without ICSI. There are some centers in the US that do ICSI on everybody because they don't want to run the risk of no fertilization. But it's not necessary. It's extra work for the lab. It's an extra expense for the patients. And so, we don't offer ICSI just kind of routinely for the average person. We use it for indications, as I mentioned earlier. Does male factor infertility affect or change the chances of a successful transfer? I would say typically no. If we have an embryo that's fertilized, is developing appropriately, once it's fertilized, it should have the same, similar chances of implantation as embryos without male factor. That having been said, there are some instances where embryos may have some developmental abnormalities related to the male factor that we're not able to determine. And so I can't say, absolutely categorically no, but in general, once we've got the embryos, the implantation rate should be fine, irrespective of the diagnosis. Question, best age to do IVF? As women get older, success rates decrease. So when we look at our success rates, women less than 35 in untested embryos have implantation rates and likelihood of live birth that's in the 30 to 35% range. And that success rate declines as women get older. Preimplantation genetic testing, so that we know that we're transferring euploid embryos, can normalize that curve a little bit more, so that older women with euploid embryos have excellent implantation rates. I don't know if I can say a best age because, the best age is when it's appropriate for you. I think that the challenge is women who present over the age of 40, have a significant decline in their ovarian reserve and have fewer embryos, fewer normal embryos, and so therefore their pregnancy rates may be lower. Do we transfer more embryos in women that are 42 to 43? If they are untested embryos, we will transfer 2, maybe 3 embryos. If they're genetically tested, we will typically transfer 1. How long do we freeze embryos? There have been pregnancies, even with older methods of freezing, from embryos that have been frozen for over 15 years. So I don't know if there is a true shelf life. I suppose it's not indefinitely, but they can be frozen for many years because they're frozen at, let's say, negative 196 degrees Fahrenheit. There are not any temperature fluctuations or they wouldn't survive. But for the majority of people who are trying to conceive, they use their embryos within 15 years, but we've had pregnancies 15 years and above. How likely is it you will get pregnant after removal of polyps? Uterine polyps are fleshy growths that you can find growing in any tissue that the underlying histology is a glandular tissue. So you can have polyps in the colon, you can have them in the uterus, you can have them in nasal polyps in your throat, etc. We think that polyps may impair the likelihood of an embryo implanting, so that we recommend removing polyps from the uterine cavity prior to an embryo transfer. I can't give you an exact likelihood. I think that we're trying to put our thought is that polyps reduce the likelihood of an embryo implanting, and with removal of polyps, then if you're 35, your likelihood of implantation should be in the 30% range for an untested embryo, 50% range if the embryo is tested. Are there specific vitamins that I recommend patients take while they're trying to get pregnant? I think all women should be on a prenatal vitamin that has either folic acid or methylfolate, and the amount of folic acid should be at least 800 micrograms of folic acid, or I think it's a milligram of methylfolate. We oftentimes will recommend vitamin D, and most of the prenatal vitamins include vitamin D. If you look at the back of prenatal vitamins, they have vitamin A, vitamin C, lots of other things. We recommend for older women adding coenzyme Q10, which is a cofactor that is in the mitochondria that's thought to impact embryo development. And there are a lot of other supplements that I'm not so sure make a huge difference, quite honestly. But I think a well-balanced prenatal vitamin is really what I recommend. I don't recommend a lot of other supplements because I don't think that there's a lot of good evidence to support improvements in pregnancy rates. I mean, some of the supplements that patients take might improve, slightly egg yield, but when you look at pregnancy rates, they're not any different. Do we have a long-term storage facility? We do have the ability to store embryos long-term, and patients also have the option of transferring their embryos to longer-term storage facilities off-site if they choose to do that. Do I recommend rest after a transfer? That's an interesting question. When IVF first started, we would have patients do an embryo transfer and then lie flat for 2 hours before they'd leave. And then we shortened that to an hour, and then we shortened it to 20 minutes. And now patients can just get up and leave. And that's based on data that shows that once you've transferred the embryo doesn't fall out of the uterus. It's transferred in a very small amount of media, and it probably floats around in the uterine cavity at the blastocyst stage up to 24 hours, but it should implant without falling out. Similarly to how if you were just conceiving naturally, the blastocyst is delivered to the uterine cavity and may float around in the uterine cavity for 24 hours. That being said, we have patients that will do acupuncture pre and post embryo transfer, and that allows them the ability to kind of rest for about 30 minutes after the embryo transfer and relax. But I don't recommend bed rest after an embryo transfer. What I would say to patients is for the first day, don't run a marathon, don't do anything crazy, but you can pretty much go about your normal activities. If the embryo is going to implant, it's going to implant, with you walking around, going to the grocery store, going to work, etc. Is there anything that you can do to raise AMH levels? So AMH is Anti-Mullerian hormone, and it's a glycoprotein hormone that is produced from the granulosa cells of the small antral follicles. So those are the small follicles that are kind of waiting to respond to follicle stimulating hormone and grow in the next cohort of follicles that could potentially develop into follicles. because AMH is produced from the small antral follicles, you can't really increase the number of eggs that you have in any given cycle. Unlike sperm, which repopulates every so many days, you have the number of eggs that you're going to have. The group of follicles that are going to be, or the group of antral follicles that are going to be available for each cohort is already predetermined, so you really can't raise your AMH levels. And, quite honestly, the AMH level is just a reflection of the number of antral follicles you have. So, they go hand in hand. It's a pretty sensitive biomarker. Can IVF be a good route for gender preference? IVF with preimplantation genetic testing for aneuploidy can be used for gender preference. Our preference is that you do this for family balancing rather than choosing gender for your first child. But if you have embryos tested, you do know not only the grade of the embryos, but you know whether they're chromosomally normal and you know the sex of the embryo. And so you can indicate a preference for an embryo being transferred back based on sex. Question about when can I advocate for Receptiva testing? So Receptiva testing, Receptiva is a test that looks at whether there's inflammation or whether that you're at risk for endometriosis. And so this particular patient has unexplained infertility and some male factor, but not diagnosed with PCOS, not diagnosed with endometriosis, except for maybe some symptoms. And there's the question as to whether or not the individual has endometriosis or not. So the Receptiva test is an endometrial biopsy is a test that looks for this specific protein marker in an endometrial biopsy. And it may indicate endometriosis. It may just indicate inflammation of the uterus. If it suggests, if you get a positive Receptiva, then your physician may recommend further evaluation for endometriosis with either a laparoscopy or may recommend empiric treatment with Lupron, a GnRH agonist, to downregulate the endometriosis before an embryo transfer. I think that some of the challenges we have with the Receptiva test is because it's somewhat non-specific. It may suggest, again, inflammation, but it may not be diagnostic of endometriosis. So I think if you're really going to go down the pathway of getting the diagnosis of endometriosis, you may want to consider a laparoscopy. I don't do the Receptiva test a lot. I'm not a big believer in the Receptiva test. I've done it on an occasion on request. And if it's positive, then we will empirically treat people with Lupron and embryo transfer, but I haven't been convinced that it's making a huge difference. I think there potentially need to be better tests that are more specific for endometriosis. Update on the use of GLP-1s with fertility patients. So GLP-1s are, indicated for weight loss. If you are undergoing fertility treatment, the current recommendations are that you stop the GLP-1 when you're pregnant, and therefore when you're, probably before you're trying to conceive. The challenge is you could try to conceive every month and not be successful for a while. So we usually stop them before you do an IVF cycle. But people are trying to conceive and are on GLP-1s. They're doing clinical trials now for those patients who have conceived on a GLP-1 just to see whether there's any adverse fetal effects. But for those patients that are undergoing active treatment, once you start active treatment, I would stop the GLP-1 just because we don't have great great data as of yet. The other thing is if you're having a retrieval, an egg retrieval, if you're freezing all of your embryos, that's one thing where you could do a retrieval, but even then we stop the GLP-1s before the retrieval because the anesthesiologists want you to be off of them prior to having anesthesia just because it slows gastric emptying and they want to make sure that you're safe in the OR. So for a patient that has had a hysteroscopic myomectomy, an abdominal myomectomy, and then another hysteroscopic myomectomy to remove scar tissue, should she go straight to IVF at this point? Or should she continue with IUIs? I would probably move on to IVF. I think that if the uterine cavity is normal and optimized, you're probably in the best position now to conceive with the myomas and the scar tissue having been removed, and IVF is probably your best option. So if a pregnancy is successful on the first attempt, roughly how many appointments, clinical visits would be required? Oh, that's a hard question to answer. I mean, there's initial consult, diagnostic testing, which the initial consult is one, diagnostic testing probably is 2 visits for the female partner and 1 for her male partner. A follow-up consult, and then we would go through treatment. And during an IVF cycle, you have anywhere between 4 to 8 appointments. I'm trying to go through. We're almost towards the end of our time. Side effects with letrozole, any increase of risk of twins. So letrozole has been widely studied in patients with anovulation or PCOS. Head-to-head studies looking at letrozole and Clomid indicated that letrozole was as effective as Clomid, and the side effect profile was much better. So whereas Clomid, which is an estrogen receptor antagonist, had lots of side effects, including hot flashes, mood swings, nausea, just kind of feeling out of sorts. Letrozole, because it's an aromatase inhibitor and doesn't block the estrogen receptor, it just reduces estrogen production, doesn't have quite as many side effects. So most women don't really complain of side effects on letrozole. The likelihood of ovulation in women who are anovulatory, I find most women ovulate with either 2.5 or 5 milligrams of letrozole, unless they are morbidly obese or unless they have very, very high androgens, in which case they may not be quite as responsive to the letrozole. So somebody was asking about the genetic testing. How long is it good for? So if you're doing genetic testing, I'm assuming you're referring to the pre-treatment genetic testing that we do, which is looking for single gene mutations such as sickle cell disease or cystic fibrosis or spinal muscular atrophy. That testing really only needs to be done once. The only thing that I would say is that as the size of the genetic testing panels gets larger and larger, you may have had genetic testing 5 years ago where we were only screening for cystic fibrosis and spinal muscular atrophy, and now we're screening women for 427 single gene mutations. So you might want to do the testing again just because we're screening for so many things. But once you've had the test, the genetic testing doesn't change. It's just a reflection of what your genetic profile is. I hope that answers that question. What are the price ranges for IVF? I think the price for IVF really varies depending on what state you live in, number one, whether you have insurance coverage or not. So rather than me getting into specifics about pricing, I would say that when you come in for a consultation, we have genetic counselors that review your insurance benefits and will tell you what your coverage is. what your copays are, what your deductibles are, etc. If you don't have insurance coverage, then they will be able to tell you our self-pay rates for IUI with and without monitoring, IVF, pre-implantation genetic testing, etc. But I can't quote you specific prices because I don't know the specifics, only because our financial coordinators handle that. Weight, is there a weight limit for women who go through the IVF process? The issue with regards to weight at Boston IVF in particular is the fact that if you were going to do IVF, it requires that you have anesthesia, and our anesthesiologists have a hard stop on anybody who has a body mass index of 45 or above. And they're very strict about it. And that's because of the safety in the operating room. If they were to lose an airway while you're under anesthesia, there's no extra anesthesiologist to help out. So we don't take care of patients who are doing IVF with a BMI of over 45. We can refer you to either the Brigham or the Mass General. They may be able to take care of you there because their IVF facility is an in-hospital facility so there are lots of extra bodies, lots of extra anesthesiologists around if something were to go wrong. That being said, even women with body mass indexes over 40, the retrievals can be more difficult. Sometimes it's harder to access the eggs, sometimes it's not. And sometimes the anesthesiologist, depending on where your body weight is distributed, are you an apple, pear, or what have you, that may affect their ability to maintain an airway. So the other issue with regards to weight, while this is not a hard stop if you're doing intrauterine inseminations, is your success rates improve with almost every 10% loss in body weight. So when we looked at a study with for patients at different body weights, the heavier you are, the lower your chances of pregnancy are. And that may have to do with the overall hormonal environment that embryos are being placed into. Genetic testing, how long does genetic testing take from Juno to genetics? Again, it's the 7 to 10 days typically. Let's see. So what is the probability of a successful transfer pregnancy if I'm 48, I have eggs frozen from when I was 38? If the uterine cavity is fine, and depending on whether I don't know if these are eggs or embryos. If the eggs were frozen and we create embryos, we can create embryos, do genetic testing, and if you have euploid embryos, the individual implantation rate of each embryo is going to be about 50%. If these are embryos that are frozen at age 38 without genetic testing, the implantation rate is going to be lower because the embryos were not tested. And so I don't know if we're transferring back a euploid embryo or not. We're running a little bit out of time and we've got lots of questions. So the question is there a wait list or something that presumably could be started right away? I think that if you want, from the time you get into for your initial consultation with a physician at Boston IVF, if you were doing IVF, it's probably 3 months to get you to do an IVF cycle. And no, there's not a wait list, but by the time you do your by the time you do your diagnostic testing, which has to be updated current within a year, we get insurance authorization, you cycle, it takes about 3 months. So right away is probably from the time of consult to 3 months from then. That I would say no waiting list. I'm going to answer 2 more questions and then we're going to have to call it quits for tonight. I have male infertility. I have sperm frozen. If my partner is a healthy female, what's the chance of a successful pregnancy if she's age 40? Well, with frozen sperm, fertilization of eggs should be fine. We may have to use ICSI depending on the amount of sperm that's available. The biggest limitation is going to be the female partner's age. And so I would probably recommend IVF with or without ICSI and doing genetic testing so we can identify chromosomally normal or euploid embryos and then transfer those embryos back. If her ovarian reserve is diminished but normal uterine cavity, you may have to consider using an egg donor. Again, it all depends on the diagnostic testing. And then the last question that I will answer is, our doctor has recommended PGT testing this time around. So I'm assuming that you've had an embryo transfer without implantation. Should we see how many get to blast first and go from there? The challenge with that approach is it's almost impossible to, switch gears mid-cycle. So we need to have an advanced directive. So we usually make the decision before you start whether you're going to do IVF with pre-implantation genetic testing. If you can put in the treatment plan if that you will only do the genetic testing if there are more than 1 to 2 blasts. I mean, you can put some caveats in, but we've got to have the plan in place because otherwise the lab can't prepare. So I would talk with your physician and, figure out a creative way to put in maybe a contingency so that if there are fewer than 2 blasts, you won't do biopsy, but if there are more than 2 blasts, you will. It's a little bit difficult to do that because we evaluate blast on day 5, 6, and 7. So over 3 days, you might have 4 blasts, but you're not going to have all 4 blasts on day 5. And that's where it makes it difficult to make those decisions. I'm sorry, I'm going to need to stop. If there are questions that have not been answered, I'm certainly happy to meet with any of you. In the chat, there's information on our website, I guess there's information on how to make appointments, etc. if you don't have a provider at Boston IVF. And I hope I've been helpful this evening. With that, I think we will sign off and join us again. I will remind you that there is a next live Q&A with Dr. Carly Nesbitt, who's one of our physicians who practices up in New Hampshire. But it's been a pleasure. Take care.